Good afternoon, everyone. Welcome to another CAR for COVID-19 Health Round. Today, we are going to be talking about dying for salt in our food and launching the CESA, which is a regional framework on sodium reduction. Today is a very, very special day. It in fact marks 1 year since the WHO declared a pandemic, the COVID-19 pandemic. I guess many of us would not have thought that we'd be here today. We've gone fully virtual, and one of the advantages is that we have been able to reach many, many more persons. But certainly, it's a day that we need to remember the number of persons that have actually been impacted and have lost their lives. Everyone knows someone who has had COVID or has been affected or impacted by COVID. And as of today, online, they reported that we had over 118 million cases of COVID-19 globally and about 2.6 deaths. And very here, closer to home, in the Caribbean region, in our CARFA member states, as of the 8th of March, we had over 500,000 cases reported of COVID-19 and almost 8,000 deaths. So this has impacted everywhere and everyone, but we have seen on the horizon the vaccination programs that are rolling out all over the world and in the Caribbean. So I encourage persons to vaccinate. Don't wait, vaccinate and get your vaccine once the opportunity arises. Today is also World Kidney Day, and on the World Kidney Day theme for today is living well with kidney disease. And so I just want to remind us of commemorating World Kidney Day, which is also linked to our discussions for today. And then we have World Salt Week that has been running from March 8th to March 14th, more flavor, less salt. So we have a lot to commemorate, a lot to celebrate, but let's move on to our exciting agenda today. So I'm your moderator, Dr. Tamu Davidson. I'm head of the Chronic Diseases and Injury Department here at CARFO. So we have our next on our agenda is we're going to have remarks from CARFO, our executive director, and from the Pan American Health Organization. We have a long and exciting program, and so we look forward to that. So let me introduce Dr. Joy St. John. She is no stranger to everyone. She's the executive director of CARFO. She provides leadership and direction to CARFO in executing the functions laid out in the intergovernmental agreement, along with the CARFO team. Dr. Joy St. John has led public health responses to the COVID-19 pandemic in the CARICOM region. She has a track record of achievements in public health systems management development and health diplomacy. Her experiences include Assistant Director General of the World Health Organization with direct responsibility for climate and other determinants of health. She has been the chairman of the executive board of the World Health Organization between 2012 and 2013. And she's also the former chief medical officer of Barbados. And she's the first Barbadian to hold that office for over 12 years, public health advisor for the Minister of Health and responsibility for oversight of the management of the health sector. So Dr. St. John will be our first speaker to bring remarks, but I'm going to go on just to introduce a representative from PAHO, and then we'll go straight into the remarks. So our next guest here will be bringing remarks on behalf of the Pan American Health Organization. Is also not a stranger. Her name is Dr. Audrey Morris. She's a public health nutritionist and is the regional food and nutrition advisor at the Pan American Health Organization with a focus on PAHO's technical cooperation in food and nutrition in the Caribbean. So at this time, I'm going to invite Dr. St. John to bring remarks, followed by Dr. Audrey Morris. Thank you.
Thank you, Madam Moderator, Dr. Tamu Davidson, who is our Head of Chronic Disease and Injury Department. Presenters, Dr. Audrey Morris, representing the Sub-Regional Program Coordinator, Dr. Keisha Roberts, Senior Technical Officer, Food Security and Nutrition of the Caribbean Public Health Agency, Dr. Said Bawa, Senior Lecturer, Faculty of Food and Agriculture with the University of the West Indies, St. Augustine Campus, Ms. Diane Charles, Community Dietitian, County of St. George West, Northwest Regional Authority. This is of Trinidad, I'm assuming. And Ms. Dinte Conway, Director, Food Policy Division, Ministry of Health, Guyana. And I also want to welcome the policymakers, food and agriculture industries, healthcare professionals, food and industry stakeholders, and civil society groups that have joined us in the audience, as well as CARFA staff. Good afternoon. I am always excited to participate and bring remarks at these webinars organized by CARFA. These opportunities to share knowledge from experts who have extensive experience in the subject matter are invaluable in building capacity in our member states. Just months ago, CARFA concluded a webinar series on the management of diabetes in primary care during the COVID-19 pandemic. The issue of NCDs requires even more attention and priority now that it is widely reported and documented that people with underlying conditions, especially NCDs, are more at risk for severe death and illness from COVID-19. We continue with the CARFA COVID-19 health rounds, as well as the focus on the tsunami of NCDs. We in the region are literally dying for salt. This topic, dying for salt in our food and COVID-19, CESA, a regional framework on sodium reduction, will help keep this issue in focus. We know that according to a recent 2019 publication of the 10-year trends in non-communicable disease mortality in the Caribbean region, that NCDs carry the highest health-related burdens and are the most common causes of death. As a region, the high consumption of salt, fat, and sugar will set up a pattern of illness and death from which CARICOM cannot escape. We have been seeing the trend in the region of high levels of obesity in children. According to the Healthy Caribbean Coalition, 1 in 3 children suffer from childhood obesity, of which sodium consumption is a major contributor. Recently published findings in Jamaica on the front of package labeling concluded that consumers who were assigned to the octagonal warning labels group made the best choices in their intention to buy the least harmful products more often and correctly identified the least harmful options and the nutrients in excess in products more often. Consumers shown the octagonal warning labels had the highest chances of correctly identifying when products were excessive in sugars, sodium, or saturated fats, of correctly identifying the least harmful option, and of choosing the least harmful or none of the products more often. Why are we referring to front of package labeling? This is important because it is a part of a regional project on childhood obesity in furtherance of the 6-point policy package on childhood obesity with CARFA as the lead agency for nutritional guidelines. The findings will inform a regional perspective on front of package labeling and are consistent with other studies around the world. CARFA Strategic Priority 3 refers to healthy living throughout the life cycle, while Intervention Priority 1 commits to providing support to improve food and nutrition security through the development of policies, guidelines, and standards, including the implementation of the 6-point policy package for healthy food environments using a collaborative and multi-sectoral approach. CARFA can support member states to build capacity through sessions such as these, where we can share best practices and innovation. The region has a lot to share, and by documenting these best practices in a way that it can be replicated, shared, and evaluated, we will have a big win for all of us. We will continue to support your advocacy for policy implementation in the reduction of sodium consumption. It is strategic that in keeping with this recommended multi-sectoral approach, we have in our audience participants from various sectors outside of health. It is my hope that by the end of this session, you will be fully sensitized to the CESA, RFSR, and the work being done to roll out components of CESA, that you will be well informed of the relevance of front of package labeling, and that you receive pertinent information on the possible interplay of salt and COVID-19. I thank you. Over to you, Madam Moderator.
Thank you. Thank you for an excellent overview as to where we are with CARFA. Now I'm going to invite Dr. Morris to now bring remarks. Thank you, Dr. St. John.
Good afternoon, Dr. Tamu Davidson, our moderator this afternoon, Dr. Joy St. John, Executive Director of CARFA, Dr. Keisha Roberts, Senior Technical Officer, Food Security and Nutrition at CARFA, Dr. Bauer, Senior Lecturer at UWI St. Augustine, Ms. Diane Charles, Community Dietitian, Trinidad, and Ms. Dinty Conway, Director of the Food Policy Division, Ministry of Health, Ghana, and all other distinguished participants in this webinar. I'm pleased to bring you greetings on behalf of Mrs. Jessie Shutan, the Sub-Regional Program Coordinator for PAHO in the Caribbean, who is unavoidably absent. Non-communicable diseases, or NCDs, are the leading cause of mortality, morbidity, and disability in the countries of the Caribbean. Making the situation even more dire at this time is the fact that persons with underlying health conditions, including NCDs, have a higher risk of severe COVID-19 disease and are more likely to die from COVID-19. Research indicates that having hypertension increases the risk of mortality from COVID-19 by 3.5 times. Unhealthy eating is a major contributor to the problem of NCDs. In the Caribbean countries, as in the rest of the region, there's widespread availability of processed and ultra-processed products and an excessive intake of certain critical nutrients, including sodium, along with fats and sugars. An essential part of the solution to this problem must be the creation of enabling environments to reduce the imbalance in the diet caused by intake of processed and ultra-processed products and the critical nutrients that they contain. In correcting this, PAHO has recently released findings of our recent study of front of package labeling in Jamaica, which Dr. St. John also just mentioned. And we look forward to the use of this information in improving the food environment in the Caribbean. Sodium targets for the region of the Americas were originally approved in 2015. And currently, PAHO, in collaboration with the WHO Collaborating Center on Nutrition Policy for Chronic Disease Prevention at the University of Toronto and Ontario Tech University, have developed a proposal of updated and more stringent targets for sodium in foods. So far, we have collected data pertaining to the current salt and sodium targets of member states in the region for different food categories and have compared the data in relation to the sodium reduction goals for the region. Out of this, we have evaluated the food categories and created new targets and subcategories. PAHO will soon launch these new regional targets and implement a dissemination strategy. Then we will also be providing technical assistance to member states in adopting and implementing the targets. We also recognize the need to monitor implementation and compliance with targets and salt reduction in different food groups and the food supply. Promoting healthy diets to maintain nutritional well-being has become more important than ever in the COVID-19 pandemic. And today, PAHO is pleased to congratulate CARFA on the development and launch of the CESA Regional Framework on Sodium Reduction. Thank you.
Thank you. Thank you, Dr. Morris, for your presentation and reminding us again the importance of front of pack labeling to the region and to our efforts to create a healthy food environment in the Caribbean. I know we love our food in the Caribbean, you know. I know we love our food and we're dying for salt, but there are many creative ways to address it. So now I'm going to go on to our next presenter and presentation. We'll be looking at the regional framework for sodium reduction called CESA. So we'll hear all about what CESA is. But before I do that, I'm going to introduce our new team member, Dr. Keisha Roberts, who is the Senior Technical Officer for Food Security and Nutrition at CARFO. Dr. Roberts has executed several roles, inclusive of consultant, service provider for food security, European Union, looking at technical barriers to trade program. She has also served as the National Food Policy Development Consultant for FAO, UNDAF, PAHO, and other organizations as well in the region and in Canada. She was also the Quality Assurance Manager and Product Development Management, skilled in commercial bakery production, Sharjah Bread Company. She was also the Product Development Technologist for George Brown College and Morrison Lamont. I hope I pronounced that correctly. She was the Quality Assurance Product Development Manager for the East Caribbean Group of Companies. To her merit, she is a holder of a doctorate of philosophy from the Department of Human Health and Nutritional Science from the University of Guelph in Ontario, Canada. And she also has a Master in Science in the Food Science and Technology from the University of the West Indies, St. Augustine, Trinidad, and a Bachelor of Science in Human Ecology, Nutrition and Dietetics from the University of the West Indies, St. Augustine, Trinidad. So Dr. Roberts comes well placed to speak on this topic, not just as one of our key experts within CARFO, but an overall expert in the area. So at this time, I will hand over to Dr. Keisha Roberts.
Thank you, Dr. Davidson. So good afternoon. All protocols observed. So this afternoon, I will be presenting on CESA, the regional framework for sodium reduction in CARICOM member states. So I will give an rationale behind the importance of this framework. I will also explain components of CESA, which are change the food environment, educate the population, strengthen systems capacity, and assess progress. Finally, I will share next steps. So the overarching rationale behind CESA, our regional framework for sodium reduction, is really to support CARICOM member states in implementing measures to reduce sodium in their populations. Excessive sodium intake contributes to hypertension, stroke, coronary heart disease, kidney stones, and gastric cancer. All of these non-communicable diseases means that excessive sodium intake results in a high incidence of non-communicable diseases. Persons with non-communicable diseases are at a higher risk for hospitalization, severe illness, and even death due to COVID-19 infections. From 2000 to 2012, non-communicable diseases were responsible for approximately 70% of deaths in the Caribbean. Reducing sodium consumption is the most cost-effective measure to lower the rate of non-communicable diseases. The World Health Organization has a goal of 30% reduction in mean population intake of salt, with the aim of achieving a target of less than 5 grams of salt consumed per day by 2025. So the CESA regional framework is supported by CARICOM, which has an intergovernmental working group that is providing solutions for unhealthy diets and obesogenic environments through the development of regional strategies, policies, and plans for reducing non-communicable diseases by reducing the excessive intake of salts, sugars, and fats. This support for a healthy CARICOM population was also highlighted by the multi-sectoral regional stakeholder meeting that took place in Jamaica from the 4th to the 5th of June in Kingston, Jamaica in 2019. So how do we implement CESA to reduce sodium consumption in populations? Firstly, we need to ensure there are measures to change the food environment. We have to educate our population, strengthen systems capacity, and assess progress. How do we change the food environment? Well, we change the food environment by reducing unhealthy food environments, by ensuring there is a reduction in access to high sodium foods. We also increase healthful environments to initiate and sustain successful eating behaviors with members of our population. This can be done through stakeholder engagements, policies, and culturally sensitive implementation. However, it is critical to understand that the greatest success has been achieved with legislation and fiscal measures. Voluntary salt reduction by food manufacturers is the ideal. However, it doesn't always work or have compliance. So, to ensure success, legislation is needed to reduce the consumption of unhealthy foods, for front of package labels, for product reformulation, and to increase fruit and vegetable consumption. So to change the food environment, legislation should look at how can we reduce high sodium contents for foods that are consistently consumed in high quantities, such as bread, baked goods, and processed meat. We need to legislate front of pack logo warnings for salt, also legislate front of pack traffic light warning labels on the nutrients of critical importance, which are salt, sugars, fats, and trans fats. We have to legislate high sodium food in school environments in order to protect the health of our nation's youth. We can also impose a public health product tax on food science sugar, salts, fats, and trans fats, while also subsidizing fresh fruits and vegetables. To change the food environment, we need to also educate the population. So when we look at CESA, the E stands for educate. Member states should conduct an individual situational analysis to ensure their health education campaigns are appropriate for their target audience, thereby identifying local dietary customs for sodium consumption. Public health education campaigns are needed on sodium with respect to front of package labels, so consumers can advocate for their health through demanding of the food industry compliance with front of package labeling. We can distribute sodium spoons to educate our public. So through those electronic sodium spoons, persons will know how much salt has been added to their foods during cooking or for purchased foods. We have to engage the public via media such as radio, television, social media, newspapers. And all this should be done through cross-sectoral collaboration between education and health, especially with respect to ensuring sodium awareness is part of the school curriculum. Continuing with strengthening systems capacity, we need to ensure there is asset mapping of existing resources relevant to sodium reduction. So for example, in your particular member state, do you have infrastructure to support sodium reduction? Do you have legislation, standards, protocols, partnerships, or even local expert committees that can assist with this? Before this is done, however, we have to identify within our member states the key coordinating agent or body to execute this asset mapping. And of course, the regional sharing of information on lessons learned and success stories will also strengthen systems capacity. Strengthening systems capacity has to have political will, and not just through the ruling party, but also through our opposition benches. Critical to success as well is funding must be identified, not only for the launch of sodium reduction activities, but for the sustainability of these activities. So monitoring and evaluation strategies could include looking at consumer behavior, looking at the economic factors, looking at trends in population sodium consumption, so we can track purchases of breads and other foods that are high in sodium to determine whether the activities we are implementing are successful. Monitoring and evaluation could also include national nutrition surveys, household budget surveys, biological measurement of sodium in urine, packaged food and restaurant food databases. And also, when we develop these databases, it is important that we know what is the acceptable quantity of sodium in each particular food. So assess. So when we look at CESA, the A stands for assess progress through surveillance. Surveillance is a critical activity for detailed monitoring of disease incidence in the population. Surveillance of chronic conditions linked to high levels of sodium intake as an antecedent, specifically surveillance of hypertension, stroke, cardiovascular disease, chronic kidney disease, osteoporosis, and cancer will allow us in member states to evaluate whether the sodium reduction activities we have implemented are actually successful. So there is evidence to support sodium reduction activities within CARICOM. The average population sodium intake or salt intake among adults aged 20 years and over in the Caribbean ranges from 6 to 9 grams per day, while the actual recommended salt intake is 5 grams a day. In Latin America and the Caribbean, high blood pressure rates are among the highest in the world, and raised blood pressure in adults 18 years and over ranges from 20.9% in the Bahamas to as high as 27.1% in St. Lucia. It is critical at this juncture to note that food processing makes the highest contribution to sodium in our diets. So what are the next steps? There must be collaboration in order for us to have successful sodium reduction activities. However, even with collaboration, there must be focus on the aim. We have to keep in mind that the goal is the protection and the health of our population. So finally, coming out of this webinar, there should be a better understanding of the critical role excess salt has on health and the key measures that can be implemented to protect our population. CARFA stands poised to disseminate our CESA regional framework for sodium reduction in CARICOM populations by providing technical support. Thank you.
Thank you, Dr. Roberts, for a comprehensive and excellent presentation. So now everyone should know what CESA is and have a strategy to implement this framework. And as mentioned, CARFA stands ready to support member states' effort to do so. So we'll move on to our next presentation, but before I do, I invite you to remember to put your questions in the Q&A section and the technical questions you have for our presenters, to put all of them in the Q&A section so that when we get to that point, we can respond to all of your queries. Also, I'd invite our presenters will also respond to any questions ahead of time during the presentation. So at this point in time, our next presenter will present on managing salt intake in COVID-19. And so Dr. Saeed Bawa is no stranger to the region. He currently holds the position of senior lecturer at the University Faculty of Food and Agriculture at the University of the West Indies, where he has been practicing for the past 7 years. Before then, he was an associate professor at the Faculty of Human Nutrition, Warsaw University of Life Sciences in Poland. He is a graduate of Warsaw University of Life Science and holds a master's and PhD degree from the university. He is currently the coordinator of the Human Nutrition Dietetics Program at the Faculty of Food and Agriculture at the UWI. Dr. Bauer is an active member of many nutrition organizations worldwide, including Community Nutrition and Chronic Non-Communicable Diseases of the United Nations Standing Committee on Nutrition, chairperson of the Committee on Exercise and Sports Nutrition, as well as nutritional oncology of the Polish Association of Dietitians, European Federation of the Association of Dietitians, where he's an active participant in the program Obesity Prevention in School Children. He's an expert reviewer of many food nutrition journals. He's authored and co-authored more than 100 journal articles, monographs, and book chapters. So Dr. Bauer comes well placed as an expert within not only this region, but globally to speak on this topic. So I'll hand over now to Dr. Bauer, Saeed Bauer. You may go ahead, Dr. Bauer. Thank you.
Thank you very much for the introduction. And I would like to congratulate the organizers of this webinar. It's of particular importance during this time. So the outline of my talk will be more or less at the beginning to tell you the danger of both consuming too little and too much of sodium. I will touch a little bit about diseases that can be caused by overconsumption of salt, and of course when there is under consumption, which is very rare. And then I will talk about where we find the sodium, major food sources, and end up with how we can save our economy, we can save money, and then divert the money to other sectors when people comply to the strategies to reduce salt intake. So without wasting much time, as I said, once again, we should know that salt or sodium is a double-edged sword in COVID-19, which means too little and too much can cause havoc. Too little has been shown, unfortunately, in recent studies to activate coronavirus, which is, I mean, very dangerous. But as I mentioned, it is very rare that we underconsume salt. So don't take what I'm saying to increase your salt consumption. And before I talk about how too little sodium can activate coronavirus, first of all, I would like to mention that rather too much of the salt can lead to obesity, as was mentioned. And all of us know that when we take too much salt, we tend to be very thirsty. And these days, we are all aware that when we are thirsty, we go for sugar-sweetened beverages, which, I mean, increases our risk of gaining weight, leading to overweight and obesity. And of course, we are aware of hypertension, major problem caused by overconsumption of salt. And recent studies are showing us that too much consumption of salt can stimulate the central nervous system autoimmunity and increase the risk of multiple sclerosis. And of course, these are preliminary results, so we have to wait for more results to come. But definitely, there is indication that too much salt can lead to multiple sclerosis. And of course, certain types of cancers can develop as a result of too much salt. And well, the only good part of salt is we can use salt to preserve food and to stop the spreading of parasites. Now, to talk about too little consumption of sodium, which has been shown to activate coronavirus. As you can see, it's a very recent study published just last year, at the end of last year, where they showed that low sodium balance can unfortunately increase the activity of coronavirus. And this mostly affects the kidneys. So people with kidney diseases will be more affected than people who are healthy. And we know that too little of that sodium increases the activity of angiotensin converting enzyme 2. And of course, this is exactly what coronavirus uses to enter our body. So if you underconsume salt and the salt is increasing ACE2, and then the virus will use ACE2, it is going to invade our body. So we have to be careful with underconsumption, which will come up later, what we mean by underconsumption of sodium. Now, just imagine that somebody is under-consuming sodium and at the same time the person is obese. We know definitely the virus is going to be very, very active because we know the adipose tissue, the fat in our body, produces angiotensin 2. And if that is coupled with too little sodium, there will be too much of the ACE2, so the virus can easily invade us. The number of the virus will be quite a lot in the body, and there will be a reduction in the clearance of the virus. This has been shown in obese people, and of course, the result is increased mortality rate in obese people who have contracted coronavirus, COVID-19. Now, when it comes to mortality rate in COVID-19 patients, we all know that, of course, there is a higher mortality rate also among patients who are hypertensive. So since there is an increased mortality rate among these individuals, and we know that salt increases blood pressure, then definitely intervening asking people to consume little of that salt, we are going to decrease that mortality rate among them. Now, talking about too much salt, right? That was about too little increasing ACE2 used by coronavirus to invade us. Unfortunately, too much consumption of too much salt leads to inflammation, too much inflammation in the body. And we all know that hyperinflammation leads to many, many chronic non-communicable diseases. So we're talking more of the danger of over-consuming salt than under-consuming it. So as you can see in panel A on the left, in physiological salt concentration, there is a balance between regulation of inflammation caused by, as you can see here, the release of M2 macrophages. And of course, there is little amount of pro-inflammatory cytokines produced by M1 macrophages. Unfortunately, panel B shows us when there is high salt consumption, the balance, the balance is off, and there is too much inflammation. The consequences, which I said, will lead to many, many chronic, non-communicable diseases. So too much salt consumption will bring about what we call cytokine storm, in the sense that, too many cytokines that cause inflammation in the body, right? And coupled with coronavirus, as you can see here, would lead to hyperinflammation in the lungs, of course, increasing mortality rate. Now, that was a little bit about how too much and how too little salt consumption can lead to havoc. Now, how much do we need sodium? Of course, adults age 19 to 50 will require about 1,500 milligrams a day. That's too little. You later, I will show you, you will realize that we can easily exceed this amount. With the elderly population, 51 to 70, they have a lower required intake, 1,300. This is because as we get older, we tend to develop salt sensitivity. And of course, then you have people above 70 years of age, which require, as you can see, just 1,200 milligrams of sodium per day. And the upper limit, all of us are aware of, is 2,300 milligrams, but most of us are already exceeding this upper limit. This is because most studies are showing that on average, we consume between 4,000 to 6,000 milligrams of sodium daily. And of course, as Dr. Roberts indicated, even here in the Caribbean region, some people even consume 9,000 milligrams of that sodium, which is quite a lot. Now, what are the recommendations? Of course, World Health Organization as well as World Hypertension League recommend consumption of less than 5 grams of salt, which is less than 2,000 milligrams per day. But remember, children will require lower amount. And the average intake of salt per adult, as I mentioned, in many parts of the world is very high, 10 grams. It is even higher in Asian countries. And of course, you can see here data from World Health Organization. The limit, once again, is 5 grams of salt. So just have a look at countries around the world. All citizens of these countries are exceeding this recommended intake. And of course, you can see Barbados here, right? And it is believed citizens of Barbados are consuming about 8 grams of salt per day, far from that 5 grams. And of course, children. We often forget that that children should also not eat too much sodium. Especially, you can see here, children aged 1 to 3 years should eat no more than 2 grams of salt a day, which is, you can see, just 0.8 grams of sodium. So that's quite a little about that. What about babies? Babies should not eat too much salt because their kidneys cannot fully, the kidneys are not fully developed to process it. Well, babies under 1 year old should have less than 1 gram of salt a day. It's not a problem if a mother breastfeeds a baby because, I mean, breast milk is providing just the adequate amount of salt as needed. So to mothers, the advice is do not add salt to baby's milk or food, and do not use stock cubes or gravy, as they are often high in salt and their kidneys cannot cope with it. So remember this advice. Now, the question is salt or sodium? Because, I mean, some of us are confused, right? when we, sometimes the label is talking about sodium, right? People don't know how to interpret that, right? So some food labels may only state the sodium content and do not confuse the salt and sodium figures. Just a reminder, to convert sodium to salt, you need to multiply the sodium amount by 2.5. For example, if 1 gram of sodium per 100 grams, then you say it's 2.5 grams of salt per that 100 grams. And once again, adults, the target value is, upper limit is not to exceed 2.4 grams of the sodium. Now, most of us these days take soluble vitamin and mineral supplements as well as painkillers. So if you routinely take an effervescent, which means the dissolvable vitamin supplement, or take dissolvable painkillers when necessary, it is worth mentioning that they can contain up to 1 gram of salt per tablet. So you can see these are hidden sources of sodium that people are not aware of and tend to develop hypertension, and they tell you that they are not eating much of the sodium. Now, talking about sodium restriction, we have different types of restrictions, right? Mild sodium restriction, which we want for the general population, that salt may be used in cooking, but no salty foods are permitted. No salt is used at the table. While if we move to a moderate sodium restriction, which is about just 1,200 milligrams, or just half a teaspoon of salt. We say no salt should be added in cooking, but that permits slightly higher protein level if needed. Then of course you will have the strict sodium restriction. As you can see, just about 600 milligrams of the sodium is allowed, which is just 1/4 of the teaspoon. As you can see, if you are on a strict sodium restriction, you are not supposed to use salt during cooking, and particularly you should carefully select foods. As Dr. Robert says, most of the sodium is coming from processed foods. So what causes a high salt intake? Of course, the salt in developed countries is largely coming from prepackaged, processed, and restaurant foods, while in underdeveloped economies, the largest source is called the discretionary and added in cooking. So the salt they use at table, the salt they use during cooking. So in developing economies, nutritional transition is increasing the exposure of populations to salt in processed foods. So most of the countries here in the Caribbean region are undergoing a nutrition transition, so they are exposed to more and more of processed foods. And this is exactly what I was saying. So you can see contribution of processed food, 77% of what we consume, the sodium we consume is coming from restaurants and from processed foods. And during cooking, 5%, at table 6%. Naturally occurring sodium is 12%. So you can see the contribution of the salt we use at home is not much. So we should pay more attention to processed foods if we want our campaign of salt reduction to be successful. And of course, this is another study showing us. So generally all over the world, most of the studies are showing processed foods contribute between 70 to 80% of the sodium we consume. And these are the major food group contributors to sodium. So starting with breads, as you can see, followed by processed meats, vegetable dishes, and then going up to, as you can see here, gravies and sauces. Now, talking about processed food and manufactured food, I specifically want to show you the big difference of sodium content when you prepare your food at home than when you buy it from a restaurant. So look at takeaway cheeseburger and chips, 54 millimoles of sodium. So 54 times 23, because the atomic mass of sodium is 23. So you multiply that millimoles times 23, that gives you 1,242 milligrams from just one meal. You are almost at your recommended intake. But look at homemade steak and chips, just 4 millimoles, which is 92 milligrams. And again, look at manufactured ready meal risotto from restaurant, more than 1,000 milligrams, but homemade risotto, look at that, just 2.3 milligrams. So you can see once again, processed foods from restaurants are the main sources of the sodium we consume. There is too much to talk here, but I'll just give an example to show you that the more you process a food, the higher the sodium content. Let's have a look at apple. Raw apple has just 2 milligrams of the sodium, but look at that. When you process it moderately, the apple pie, per serving will have 208 milligrams. So you are going from 2 milligrams to 200 milligrams. And then highly processed apple pie from fast food restaurant, 400 milligrams. So you can see once again, the more you process, the more you have. And let's have a look at tomatoes before I move to the next slide. The good news is that for the participants here, the slides will be provided to Dr. Roberts after the webinar, and I think she should make it available on CAFA website so that people can download it. Now, let's look at tomatoes. Raw tomato per serving has just 14 milligrams. When you process that into salsa, that gives you 200 milligrams of sodium per serving. And what about tomato sauce? Look at that. You are already at your recommended intake per serving, 1,500 milligrams. So once again, you are seeing the more you process a food, the higher it is. Now, we have to be careful when we ask people to reduce the amount of salt they use at table or the amount of salt they use during cooking. Why should we be careful? This is because usually the sodium we use at home is iodized. So if you ask them to limit it, they might be deficient in iodine, and iodine prevents many diseases, among others, non-communicable disorders. So that we should concentrate more on processed foods. This is a study that was carried out at the end of the 1980s. Look at that. These are patients who were hypertensive, hospitalized. They were on a normal diet. They were consuming 3,100 milligrams of sodium. as you can see here. And then at hospitalization, they were given low sodium diet, 1,600 milligrams. But then in the hospital there, when they were provided meals, the hospital staff provided them with salt shakers at the table. They allowed them to use as much as salt as they wanted. But look at that. Despite allowing them to use as much as salt they wanted with the salt shaker, they were not able to go back to their normal diet, the diet they were on before they were put onto a low sodium diet. And as you can see, once again, pay more attention to processed food and not the salt we had at the table. It's not a problem. And these are other hidden sources of the sodium. As you can see, as we use sodium for preserving foods, you can see their names. It starts with sodium, and on the right, these are the foods we preserve with these foods. Now, talking about limiting salt intake, right? So we should carefully look at labels and know how to read labels, right? And unfortunately, studies that were conducted by some of our students at UWI found out that not so many people in Trinidad and Tobago know how to read labels. So what does it mean sodium free? It means it must contain less than 5 milligrams of sodium per serving. A very low sodium must contain, as you can see here, less than 35 milligrams of sodium per serving. And what do we mean when we say reduced sodium? A food has reduced sodium. It is 75% reduction in sodium content as compared to the regular one. And of course, as I said earlier, many diseases can develop as a result of too much consumption of that salt, particularly, of course, talking about here, stroke, which has been shown in EU countries where there is higher consumption, there is a higher prevalence of hypertension and stroke. So high salt intake, no doubt about it, increases mortality rate from coronary heart disease, cardiovascular disease, and all forms of diseases. So while lowering sodium intake has been shown to be effective in lowering blood pressure in both normotensive. So you can see, even if you have normal blood pressure, you decrease your salt intake, is going to help you lower the blood pressure. Not talking about hypertensive individuals, as you can see here. So these are the meta-analysis showing us once again the importance of lowering sodium intake to drop blood pressure, and of course recommendations worldwide saying if you reduce your intake to the even upper limit, look at that upper limit, 2.4 grams, blood pressure may go down to even 8 millimeters of mercury, which is of importance. Another recommendation, when you go on a diet that is rich in fruit and vegetables, low fat dairy and reduced in fat, what we call the DASH diet, which is low in sodium, you will have perfect results. So this is the DASH eating plan, which I mean at a later time, when you are able to download this, you can go after it. So that's the DASH diet. You can see when you are on that diet, no doubt about it. Look at that. Even when you consume 9 grams of that salt, you are on that diet, there is a decline in systolic blood pressure. Not talking about when you limit it to 3 grams of the salt, as you can see here. So this brings me to the end of the lecture, because the other 2 slides is just showing us how English people were able to save billions of pounds when when they went on campaign for lowering salt consumption by citizens of the UK. So I think similar things can be achieved here. So I thank you for listening, and I'm sure I exceeded my time. I will welcome any questions from you. Thank you very much.
Thank you, Dr. Bauer, for a very exciting, comprehensive, and stimulating presentation. I felt I was right back at medical school following you each slide bit by bit. And we will look forward to sharing the presentation with everyone on this webinar. And if you have any questions, please put them in the chat. Thank you. I'm going on to my next presentation by Miss Diane Charles, and this presentation will look at my plate, my palette, purchasing food and COVID-19. Miss Diane Charles describes herself as a God-fearing, meticulous professional that is adept in nutrition and dietetics, both at the hospital and community level. She has 37 years of experience in managing the nutrition and dietetic services in general and district hospitals and providing medical nutritional care, as well as planning and implementation of public education and training programs in collaboration with local and regional agencies, which complements her clinical experience. Ms. Charles is a graduate from Robert Gordon's University in Aberdeen, Scotland, and a registered dietitian at the Republic of Trinidad and Tobago. She is the past president of both the local and regional Nutrition and Dietetics Association. Her experience has spanned the Caribbean, being employed in the British Virgin Islands, where community dietetics opened a whole new world to maximize opportunities to empower and encourage the client and enhance personal skills. Ms. Charles is also a certified breastfeeding counselor, a Toastmaster. She is a computer literate with basic skills and has a passion for the game of cricket and an addiction for the game of chess. Ms. Charles, I hand over to you.
Thank you very much, Madam Chair. Dr. Joyce St. John, Executive Director of CARFA. Can you hear me?
Yes, we can hear you.
Okay.
Yes, yes, thank you.
Dr. Audrey Morris of PAHO, distinguished fellow panelists, Dr. Roberts, Dr. Bauer, and Ms. Conway. Fellow colleagues in nutrition and dietetics, ladies and gentlemen, it is really my pleasure to be here with you today as we delve into this topic of reducing salt within our diets. I want to put a disclaimer at the beginning. I had no conversation with Dr. Bauer. We never compared notes. Whatever you see before you when I present, please. It just so happens that maybe both of us are thinking alike. Next slide, please. I wish to agree with Dr. Davidson when she mentioned that we love food and that food forms an important part here in the Caribbean. Whether it's the cuckoo and flying fish from Barbados, or the delicious pilau and zabaka, as we say in Trinidad and Tobago, or maybe the roasted breadfruit and jackfish from St. Vincent. But what about the ackee and the dumplings and the lovely roti, the pepper pot? We can go on. Every single dish that we can think of, it's unique to us. But I ask you a question today. Where is it? Where are these dishes now? I am going to take my presentation. Next slide, please. I'm going to take my presentation a bit from some things that Professor Sir Hilary Beckles mentioned when he was delivering a lecture recently in St. Vincent. And he spoke about some quotes I'm going to take from it. He spoke about the Black people in the Caribbean. They are the unhealthiest people on the planet. 60% of over the age of 60 years have hypertension and diabetes. Black people in the Caribbean cannot metabolize salt and sugar. He went on to explain about the hypertensive drugs, and they have a 90% response in Caucasians, 70% response in Afro-Caribbean people. Next slide, please. These facts made me think. And as I was invited by Dr. Roberts to share with you today, click again, please. I would like to focus on one aspect of CESA, that of educating the population, especially in the area of communication and advocacy. My presentation is going to be as practical. I'm going right down to ground zero. My work involves working in communities, and I really am a very practical person. We try to get to where the person is, so that I'm going straight into the kitchens. I will be going into the clinics. I will be talking of how we spread our message in order to get this message across of reducing salt in our diets. Next slide, please. Let's look at communication from 3 aspects: language, listening, and literature. Next slide, please. Now, we just saw a slide, and I still have it up because it's important. When we are getting that message across, are we talking about salt or sodium? The average man in the street knows of the little white crystalline substance, which nowadays is also pink, black, and gray. And let me say at the onset that that's one of the things that we get right off the table. Whatever the color is, it is sodium at the bottom there. So that we try to explain to individuals, if you're going to use the pink salt, you do not use more of it. If you're going to use the gray salt, you do not use more of it. Next slide, please. So that if we speak of salt in these areas, click again, we look at the processed foods, and it comes to the fact of reading labels. Now, my take is, if I am counseling persons and I have to be explaining to them about food labels so much, my first question to them, why are you eating out of boxes and cans so often? But it's a fact. The life that we have to live now, and more so when COVID is in effect, but I mean, it has improved somewhat. But what I'm saying is that persons are going to find themselves using more of these processed foods, and we have to teach about the label. But is it only the label? What about the ingredients list? Persons out there, some of them look at it, but they're looking at the calories. They are looking at this label, and they are seeing serving size 1 cup, thinking that maybe to them, their serving size is more than 1 cup. And we need to make sure that when we are getting this language across, this communication, that we are speaking for them to understand. Click again, please. They need to know, click again, they need to know the natural sources, as was mentioned before. The eggs, the beef, the meat, the chicken, these things contain the sodium levels, and they have to understand this. Because if they don't, next slide, please, they are going to assume that they can freely eat it as much as they want. We try to get across the taste factor. Taste is not only salt. You and I, when we have a plate of food in front of us, we see it first. Salivary glands get into action. But then when we put it on the tongue, we expect a taste that's out of this world. As Professor Hilary Beckers indicated in that lecture, he spoke about the slavery days. And the slavery days, there were a lot of salt pork, pigtail, salted items. And that is how we seem to have developed this taste for salt within the Caribbean. But there are other things out there that can help to season the food. It is just that we don't use it. We are so hooked on garlic, black pepper, pepper sauce, salt. We don't remember that there is curry, there's rosemary, there's paprika. These are the things that we want to get the individual to understand. Mix and match. You don't take the dry mustard, the nutmeg, the onion, the sage, the pepper, ginger, and put everything, because certain items may not be applicable. And we encourage the persons mix and match because your taste buds are going to be different. Next slide, please. Label lingo was already given to us. Next slide, please. Our language must include portions. When you control your portions, you're going to control your sodium. There is a little thought that keeps resonating in most of our clients, and it's only that crystalline white substance. But if you put too much of that crystalline white substance all over and you have large quantities, you're going to be in trouble. On the other hand, if you don't control that amount of meat, fish, chicken, eggs, all those naturally containing sodium items, you're also going to be in trouble. So we also speak about the portion plate, where we advocate a quarter of the plate to be starch, a quarter to be the protein part, chicken, fish, the peas, and a half a plate to be with your vegetables and raw or cooked, etc. So that portion control is important. Next slide, please. But we don't understand that in the Caribbean. Wherever we go, it has to be full up the box with all the base of the starches, throw your meat on top. If I don't see meat, don't give it to me. If I'm paying for a box of food, I expect to see a lot of meat. Next slide, please. But we have to listen to our client. Click, please. We have to listen to our client. Click again. Our client will have their challenges. Finances. Who is the breadwinner in the family? Here we are telling a population, a community, listen, we have to talk about reducing salt in the diet. But where's the money coming from in the first instance to buy the food? Is there money? Perhaps it's a single parent who is just one of those local government workers and the income is small, but there's a large family to take care of. Perhaps it's a full family, but husband does not have a job that will allow the food item. It's barely enough. And you have to meet the person at that point. Yes, we need to reduce salt in the diet, but maybe Mrs. John, Mr. Harry can only afford to give his family a plate of pigtail, okra and rice, and maybe chicken foot, stewed chicken foot. We cannot make them feel that's not acceptable. It depends on how much you're having, and then we work with them and say, okay, why don't you spend the money this way? So a part of the budgeting is also involved in that, because we want at the end of the day that they're going to get the meal that is going to be controlled. And we're not talking here about whether you're losing weight. We're talking here about a general population. That same matter with finances is the work versus the time for meals. COVID is a perfect example, because now it's the second job. Sometimes in some instances, the third job, leaving a 12-year-old to look after a 3-year-old. And what I'm saying is reality. I am seeing it. I speak to it. I hear them. I am the one that has to react and counsel. And it is not easy. And you have to understand, how am I going to tell her that she cannot go out when she's coming home and buy a box of KFC to bring it home for the children, or open 2 tins of Vienna sausage and throw some spaghetti mac cheese from a box in it? She will tell you, Mom, I have no time to stand up. And cook a plate of food. So we have to tell them and guide them as to how they can do this. Click again, please. Food choices, the meals at home. And I alluded to some of that just now. How many times are they eating? Some of us leave the house with just the cup of tea, and tea in the Caribbean is a lot of things. And then maybe 3, 4, 5, 6 hours after, when the stomach starts to growl, looking for the food. And sometimes it's not that I'm eating meals at home because I'm looking for it outside. So I hardly eat the meals from home, okay? Food accessibility. They access the food. We want them to eat certain things. Can they find it? So you tell them, go to the market and get X, Y, or Z. But maybe the market is a long way off because the grocery store around the corner, and I'm not talking about a Massey store because Massey is known in the Caribbean. I am speaking about the little corner shop that goes out to the market and then brings the items and increases the price for those at the corner. The corner shop is very important to me as a community dietitian because that's who I link up with when I want to do certain things. I want to hear what it is. I want to know what you're selling because I want to know what my clients are going in there to buy. So the food is not always accessible. It may not always be available. So we want to reduce the salted items, the saltfish, but then individual has no fridge. How are we going to let her get fresh fish? Or even if we say, don't buy too many tinned foods, we say, okay, if you have to buy the tinned foods for a certain period, get the one in water. We have to understand, I'm hoping I'm getting the message across because we need to come down to where they are. Next slide, please. So I'm going to just flip through some of these things again. Next slide. These are just giving us ideas again of quantities of food that persons produce on the sodium content. Next slide again. Next slide again. These are all just pictures of some of it, Dr. Bauer. Now, what matters? Let's go through the literature. Click again. We have to think of literacy, font size, and the foreign language. Literacy, very important. All these lovely, beautiful literature that our department wants to produce, and we put it into the health centers. We see it on the floor, or we see it by the corner shop, when half the time they can't even read it. Pretty pictures with colors, font size so tiny, they can't even see it if they can read. Foreign language, we have people among us where we have to go out there and start to learn the Spanish, etc. Next slide, please. Educating the population, and I'm going through this quickly. So we have to look at advocacy. Who are my advocates? Who am I approaching? Maternal and Child Health Clinic, the NGOs, chronic disease. Next slide, please. These are the clinics, and I'm just showing you, as I've just a few more slides. We are looking to create supportive environments, develop personal health skills, so that we find ourselves linking up with local government. I myself, just one quick example, my local government counselor in one of my areas, I have liaised with her and we've worked together. This was before COVID. We've worked together in schools, but she will help us in programs. And it was working together because of her interest in getting her community to be able to be healthier, but with mainly among the children. Next slide, please. So we spoke about developing personal skills, working with people, and empowering communities to achieve well-being. So we have our health camps for children, and again, sorry, but that is the community that we tend to, when we are dealing with the maternal and antenatal, we try to get mothers, same thing similar to what Dr. Bauer spoke about how you're going to feed your child. Don't put that salt on the food. Children should not have extra salt until they ask for it. So we do make sure that when we're speaking about the food mixes and the multi-mixes and introducing solid foods, that's where we will talk about the salt intake, the sugar intake, the fat intake. Next slide, please. And I'd like to close with the words of Nelson Mandela. Education is the most powerful weapon which you can use to change the world. Next slide. Thank you very much, ladies and gentlemen.
Thank you for another excellent presentation, Ms. Charles, on today's webinar. Isn't it great, exciting? We've learned quite a bit. So I'm going to our last presentation for this session. The next presentation will be on the regional sodium framework reduction, a CARFA member state perspective from Guyana. And we have Ms. Dinte Conway. Ms. Conway has held the position of Director, Food Policy Division from the Ministry of Health, Guyana, from 2016 to current, and she holds a Master of Science in Public Health Nutrition at the University of Westminster in London. Ms. Conway strives to promote balance in the lives of persons with positive health and life changes. Her department at the Ministry of Health Guyana aims to promote adequate nutritional intake for all residents to enjoy healthy, productive lives for sustainable economic growth and development, with activities aimed at ensuring a high standard of nutrition for all age groups by providing general nutrition education for the population through community nutrition programs and outreach. At this time, it's my pleasure to hand over to Ms. Conway. Thank you.
Thank you so much, Dr. Davidson. Good afternoon, everyone. Dr. Joyce St. John, Dr. Audrey Morris, Dr. Roberts, Dr. Mawa, Ms. Charles, and all of the attendees on this webinar. I really would like to thank Carrefour for having Guyana present today on some of the activities we've been doing for the reduction of salt. I really wish that we could have a round of applause for all the presenters. It was really, really good to listen to everyone. I know, Ms. Charles, you said that you're wondering, Dr. Bao's presentation had, a lot of things that you talked about. It's because we have the same agenda. We want to achieve the same goal. So a lot of things I would say too will relate to you and some of the other presenters. So let me just get right in.
Sorry, could you put on presenter view? Thank you.
So Guyana is no different for the NCD rates. 6 to 7% of our total deaths are NCDs account for that. So we're no different from our Caribbean sisters. Our hypertension rates are very high. The prevalence are very high. I have data up to 2015, and it's males 24.5%, females 21.5%, and overall it's 23.1%. Really, really too high for our population. So we have several agencies working on NCDs reduction. We have the Presidential Commission on NCDs that was reconstituted in January this year because we had a change of government. So they have several agencies on that commission: private sector, government agencies, NGOs, the university, religious bodies, a wide cross section of agencies. We have the Ministry of Health Chronic Disease Unit, and we have the Ministry of Health Food Policy Division that I am part of. And today I'll be presenting a bit on what we do for healthy eating, but specifically what we've been doing for salt reduction. So our mandate at Food Policy is really to provide general nutrition education for the population through community nutrition programs. And we assist in the development and execution of in-service training of all public health staff, as well as staff of other agencies in the principles and practices of nutrition, with particular reference to indigenous foods. And this fits into the E of your CESA framework, educating the population. We focus a lot on that. So some kind of, I would say, indirect activity for salt reduction, but which has a direct long-term positive impact, is promotion of exclusive breastfeeding for the first 6 months and infant and young child feeding. So breastfeeding, I believe, really is the foundation for the start of good nutrition, right? Where breastfeeding means adding nothing else, nothing to the baby for the first 6 months. And most importantly, nothing means no salt. And we know that the baby can, that is the best food for babies for the first 6 months. And if we can get this right, if we can get mothers and grandmothers and everybody who have an impact on the baby's life to get this part right, it's also, the psychology of the person growing up to know good nutrition, how the good nutrition has started. So we've had some good progress with regards to promotion of exclusive breastfeeding in Guyana. We have the certification of 11 hospitals as baby friendly, and we know this is a good intervention. This is a good step towards getting improving our breastfeeding, exclusive breastfeeding rates. So we do a lot of training, BFHI 20-hour training with our healthcare workers. We have the new 10 steps that were developed. We do a lot of training in that. We've done breastfeeding counseling and training with healthcare workers. Since COVID, we've done a lot more radio and TV appearances because we can't get to go out into the field as before. We're really still trying to adjust to not being able to practice the social distancing, and so we have to use a lot of online medium. And so infant and young child feeding counseling and training, for this year we're restarting our physical interactions with healthcare workers, but at a minimum we have the required number of persons that can attend the training. And so because really we don't want to get off track with breastfeeding. We had a lot of feedback of persons don't wanting to breastfeed because of COVID, whether you suspect you have COVID or even if you do have it, that is still safe to breastfeed once you follow certain guidelines. So we really had to do emergency training on that so we could keep up the momentum of promoting our exclusive breastfeeding. We're working on the code of marketing of breast milk substitutes, and this code, I think it's one of the PAHO's unhealthy diet reduction measures. We had a lot of consultations with it, and even during COVID, we've had a lot of online consultations with this. And it's right now with our PAHO's Washington office being reviewed. So we hope we can get this at some point go to cabinet so that we can move forward with this, because this is an important obstacle right now that is blocking a lot of marketing of these things are going on. When you go into the supermarket, it's right there in front of mother's eyes, and as people, breastfeeding has its challenges, but to have these things also impacting on our on that. So direct activities for salt reduction, we use the food-based dietary guidelines as the umbrella. We have 9 guidelines, but one of them specifically talks about reducing, I think my label has shifted, use more natural seasonings and less salt and salty products. And this really, I love the theme for this year's Salt Awareness Week, more flavor. And where do you get more flavor from? Your natural seasonings. So we've been doing a lot of training using the food-based guidelines with health practitioners. We want them to, because these guidelines are really, really practical to the ground. We have a lot of examples how you can incorporate using more flavor into your food and not use so much additives. And it's just not just the salt, it's the cubes, the soy sauce, ketchups and all those things. So it's not just the word salt, right? We try to get that message over to persons. So they we use the guidelines to do the training with the healthcare practitioners at the health facilities and the clinics that they're a part of, because they're one of the first contact at the primary healthcare setting with persons. And our community nutrition officers also go and provide support at these health facilities to do training, to do counseling with persons, and we do a lot of practical. What I've found is that even with all the theory, all the handouts and so, it doesn't matter what you tell people, when you actually turn up at your stove and the foods and you cook it in front of them and show them how the food tastes with the less salt, and you put in all your add nice seasoning and ginger and turmeric and all those things, it makes a huge difference when they can taste it without having to go home and say, let me see what this nutritionist was saying. when you can taste it right there in front of you, you can see the difference it makes. We go to schools and we have nursery school children tasting callaloo drink and loving it. I'm sorry I couldn't get the video to upload. Young children drinking things that usually you might think that they would, they wouldn't accept. But the practical work makes a big impact for a person. What I found. We before COVID, we started with the school curriculum. We wanted to have the new FBDGs adopted into the curriculum with the home economics teachers. We had one session with them, but during COVID, we've had a lot of challenges to do online training. The teachers are, at it all day online, so to fit in training in that has proven to be very difficult. We're still working on that to see how we can continue to get this into the curriculum. Recently, we had some live call-in programs during COVID where we were giving information and so on salt reduction, and we had a call-in. The response was amazing. People, we thought we had it at different times, point in times, nighttime, even early afternoon, midday, and a lot of people respond. We were very, very surprised. Some of the prizes that we gave out were actually plants, so time plants. It was already in the pot, and we had good responses for that, so that you could take that home and have start. It's like the start of a small kitchen garden. You can use these nice herbs and spices for your foods. We also are planning to do a supermarket tour Facebook Live. So in addition to an advertisement that we developed about reading food labels, you're in an environment where we walk through the aisles and without trying to show a brand and labeling it badly, showing you about how to read the labels, at least the ones that are, at the back of the product, which is very difficult even for, people who should know to read it, much less the normal man in the street. So we wanted to have that setting where people go to shop and find some of the popular products, including cereals that people think are so healthy for their children, and so to show what to look for in these products, what to not, what to avoid. And it might be every day. You might not be able to avoid these things every day, but have that balance, be aware of what you're, even if you're consuming it, you must know, well, I'm consuming something bad or I'm consuming something good. You need to be aware, that people need to be aware to have that option for themselves. So I'll stop there for now. I just wanted to share a commercial that we did. Food labels have been a sore point for us here. We've now really paid attention to it as it, the attention that it needs. So we've developed this commercial, and this is in-house, and this is a staff of the food policy and nutrition officer who did this. So I just wanted to share with you what it looks like.
There are 9 food-based dietary guidelines Indiana for you to follow and live a healthy life. Guidelines 5 and 6 deals with sugar and salt consumption. An important step we can take to watch our sugar and salt consumption is to read food labels. This is very important as there are a lot of sugars and salt in many of the foods we eat and drink. So when we are reading the labels, we need to look, for instance, at the sugar content and the amount stated, and multiply that by the servings per container to know the total sugar in the product. Or we look at the salt or sodium content and the amount stated and multiply that by the servings per container to know the total salt in the product. The daily recommended amount of added sugar for males and females should be 6 teaspoons or less, and the daily recommended amount of salt should be less than 1 teaspoon. For instance, the amount of sugar in this size of soft drink could be as much as 16 teaspoons, and in this kind of drink as much as 10 teaspoons.
Please, let's pay attention to what we are eating, as overconsumption of unhealthy foods leads to many illnesses, including high blood pressure, obesity, and heart disease.
Come on, Guyana, let's use the food-based dietary guidelines to reach for a better life with good health.
So that's it. Thank you very much.
Thank you, Ms. Conway, for another excellent presentation. If you're able, please share a link to that video, which was very, very informative, in the chat. So at this time, we'll go to our question and answer. I think we have resolved all the questions. Do we have any additional questions in the chat box? No? I don't see any further questions from our participants. So I know we are running over time, but the presentations have been awesome, great, fantastic session. So at this time, I'm going to invite each presenter just to leave us with, just briefly leave us with one or two take-home messages that you would like to leave with the people in the Caribbean and people on this webinar as it relates to reducing sodium consumption, and by extension, really trying to make the Caribbean a healthy, create a healthy food environment in the Caribbean region. So I will start with Dr. Roberts, our first presenter, and then I'll move on. Yes, thank you. Please unmute, Dr. Roberts. Thank you.
Thank you, Dr. Davidson. So coming out of this session today, I am hoping that persons within our region are aware of CARICOM's drive to ensure our populations are healthy. And not only that we at CARFA are a resource.
So we're losing your sound? Yes, thank you. You just lost your
I'm not
sound.
hearing her.
That we at CARFA are a resource technically and practically to help with the implementation of CESA, which really is about reducing sodium consumption in our populations. And one of the greatest driving forces to ensure success in this is to ensure that we are advocating for front of package labeling. And this front of package labeling must be easily understandable to our consumers, so they do not feel as if they're going through an exam, just to ensure that they are purchasing foods that are healthy. I think coming out of this as well, it is clear that there are success stories in CARFA and CARICOM member states. And so it is great that we can have a repository for this information that we can share with our members. Thank you.
Sorry, thank you. I unfortunately got cut off. That's the challenge of the working with in a virtual setting. So at this time, I'm going to invite Dr. Bauer to give us a key take-home message at this point in time. Thank you, Dr. Bauer. Over to you.
Yes, the home take message will be for the Caribbean people to eat more foods at home, more homemade foods than processed ones, or than eating in restaurants, as I have shown it's not only related to too much consumption of the sodium, but also when you are at a restaurant, you tend to eat much more than you require. So hypertension and obesity, right? So just imagine at home, you just eat one dish, one main course, and that's all. You go to a restaurant, they start with giving you the so-called appetizer. Sometimes appetizers have 500 kilocalories, and then later they tell you, oh, now it's time for the main course. They give you the main course, you might be eating 1,000 kilocalories, and then later they say, oh, it's time for dessert, right? So you end up overeating, meeting already your recommended energy. So what do you do later? When you go back home, you eat something which will lead to overweight and obesity. So once again, it's go back to tradition. I mean, to Caribbean people, when I'm talking about go back to tradition, start growing in your yards breadfruit trees, right? And you know, breadfruit is one of the perfect foods you can find in the Caribbean, low glycemic index and low sodium and so on. So back to tradition once again. Thank you.
Thank you, Dr. Bauer. And so at this time, I'm going to invite Ms. Charles to give her take-home message.
Thank you, Dr. Davidson. Let us appreciate our food in the Caribbean. And even there's so much similarity. Yes, we have to look at reducing salt, but let us also think of the client. We are in different times and challenging times, and we want people to do our part, but we have to understand that the client as well. And I'm urging my colleagues out there that let us just be practical. We know the book, we know the numbers, but let us try and be practical. Those of us in the community, we need to work within our community, because we can't help everybody all of the time, but we can work with the chosen, with the selected few that we have to deal with. Thank you, Dr. Davidson. And thank you again for letting me be part of this fantastic session.
Thank you. And thank you, Ms. Charles. And now we'll go over to Ms. Conway. Thank you.
Thank you so much. So I want to appeal to the Caribbean population. We have this environment that is overwhelming us with these unhealthy foods, but we want you to come on board with nutritionists, listen to our messages. You know, I mean, all of us are heading, we will die one day, but we want the life that we have, we want you to be healthy. When you're healthy, you live such a really, really nicer life. You don't have aches and pains, your knees don't hurt, you don't have to depend on medication. Listen to our messages. We're really working hard on the ground for you. Thank you.
Thank you. And now I invite Dr. Morris just to say a few words, take-home message that she'd like to leave us with.
All right, thank you very much for the opportunity. And it was good to have participated in this webinar, and the presenters were excellent, if I can say so. I just want us all to be aware that right now we have to emphasize the issue of the food labels and the octagonal warnings, for which there is one on sodium. And so that, I think that's my take-home message, the need for front of package labeling that consumers can understand so that they can make the healthy food choices. We're at a point now where our regional leaders are at the decision-making point, and so we have to encourage them to make decisions based on evidence that will benefit the people of the region. Thanks.
Thank you, Dr. Morris. And finally, I'm going to invite Dr. St. John to give us her take-home message as head of CARFL. Thank you.
I'm really glad that we were able to come together. even on the anniversary of one of the worst, the start of one of the worst periods in the history of the world, and come together to be constructive about dealing with something that is the first pandemic that we were struggling with, the pandemic of NCDs. I had to go to another engagement, but I didn't miss too much. But what I got was so rich, especially what I got from the member states, that I feel encouraged. And I have always felt that the Caribbean does not have enough nutritionists, but when you have nutrition programs which are so powerful, the power of the passion that I heard today makes up for the lack of numbers. But we will get there. I want to thank you, Dr. Davidson and Dr. Keisha, for putting this together. And I want to wish everyone to be safe because we're still struggling with COVID-19. So I want all of us to try to be safe in our respective countries and sectors. Thank you very much, Dr. Davidson.
Thank you. So you heard it. We are stronger together. We in the Caribbean can do this with the passion, with coming together and working together towards going back to basic. We've heard it. We need to go back to basic. We need to put the client at the center. We need to put our people at the center of really trying to address this problem. And front of pack labeling, ensuring that we know, we have a right to know what is in our food. And certainly the octagonal warning label has been proven to work in our setting. So today we end this webinar, Dine for Salt in our food, salt awareness, and COVID-19. And so I'm going to invite you to click on the link. We should have shared a link for the evaluation. You'll also get follow-up emails so you can do our evaluation because we want to come back to serve you and to improve on what we're doing here. We want to know whether you enjoyed the webinar, what things and suggestions you may have. You can also include any additional questions that you may have that you would like answered. At this point in time, I'd like to thank all our presenters. I'm going to ask them to just turn on their video. I'd like to thank you for really the excellent, superb presentations today. Shows just a demonstration to show that the Caribbean has the expertise, we're on track, and we're working together. It's united as a Caribbean region that we will be able to tackle the pandemic of NCDs. Thank you, everyone. And there's a saying that says, walk good. Aye, aye, aye. Bye, everyone. Thank you for coming to the webinar today. We look forward to seeing you on the 31st of March for those who will attend the final webinar for the diabetes module. Thank you, everybody. And thanks to the support team for CARFA for the superb job that you have done in helping to organize this webinar. Thank you, everybody.
Thank you. Take care.
Yes. Thank you. Take care. Thank too. you. God Thank bless. you. Bye.